You are listening to The Addiction Files, where we discuss evidence-based treatment, clinical pearls, and resources while striving to destigmatize the treatment of addiction in our medical culture and save lives. We are the Addiction Doctors, Dr. Darlene Petersen and Paula Cook. Welcome to this episode of The Addiction Files. We are excited to be back in the new year. We are talking about psilocybin and all about magic mushrooms tonight. Just as a brief intro, psilocybins are a naturally occurring psychedelic. And really this chemical, it's a prodrug. It's produced by multiple species of fungi out there. Comes from the genus Psilocybe. It's converted to psilocin. That is what has its mind-altering effects, which is most similar to what we think of as our kind of classic hallucinogens. So that's our LSD, mescaline, DMT, those kind of things. We'll kind of talk a little bit about some of the pharmacology, and then we'll get into the mechanism of action, some of the effects. And what we really want to talk about is where the research is going on this. We have some research and studies into depression, some of the use with alcohol use disorders, and even nicotine. We'll talk about that.
Sounds good. Sounds great. Should we talk really quickly about the history of psilocybin and magic mushrooms? Just a brief.
Yeah.
Okay. So, magic mushrooms, it's plant medicine. They've been around for thousands of years, mostly used in religious ceremonies dating back 6,000 and 7,000 years ago. We have an earliest known record of mushroom use in the 1500s in a manuscript of ethnographical research of Mesoamerica called the Florentine Codex. So this describes use of magic mushrooms by the Aztecs in Mexico. Obviously, then, we start seeing other hallucinogens pop up in history, including isolation of mescaline in the late 1800s. And then PCP was synthesized in the early 1900s. And then, of course, you have Albert Hofmann discovering LSD in 1943 and taking it himself and kind of booming the emergence of psychedelics into the early 1960s. Around this amount of time, you see the synthesis of ketamine as well. And then you see the psychotherapeutic drug manufactured by Sandoz Pharmaceuticals called Psilocybin, which was actually a psilocybin drug. And things were kind of booming in the 1960s, as we all know, in regards to psychedelics. But then the Controlled Substance Act was passed in, I think it was 1974, wasn't it? The Controlled Substance Act, banning classifying psychedelics as Schedule I medications and therefore restricting research. And so really, we haven't had a lot of advancement in research of psychedelics and psilocybin from that time until recently, when we started having more interest and more publications on psilocybin and other psychedelics for the use of, like the things that Darlene was just saying, and especially a lot of work coming out of Johns Hopkins University. And they've built the Center for Psychedelic and Conscientious Research just recently, but they have a lot of good research that's been coming out of there. So it gives you kind of a brief history, but we do have this kind of gap in time from 1970 until kind of the early and mid 2000s in terms of research. But now things are really picking up speed because interest is peaking as we're looking for alternatives for treatment-resistant depression and treatment, of course, for substance use disorders. And so this podcast, of course, is interesting to us as addiction medicine professionals because psilocybin is a drug that's considered one of our abusable substances, right? It's one of our things that we screen for on a drug history. Although it doesn't have a use disorder classification in the DSM-5, people don't typically have dependence, tolerance, withdrawal from psychedelics or mushrooms. So we're going to talk briefly about that, but mostly move forward, as Darlene said, with some of the research for its therapeutic approach.
As we kind of alluded to, it's called an endolamine hallucinogen. like I said, similar to LSD, it works on dopamine and serotonin, as opposed to what we think of as our more dissociative hallucinogens. That's like your ketamine, DXM, PCP, those type. It acts as a serotonin 2A and 5-HT2A receptor partial agonist, and it acutely decreases the resting state connectivity with the default mode network. And this part is the most interesting, as why we think it's maybe efficacious for depression and alcohol use disorders. We'll get into a little bit more detail a little bit later when we specifically talk about those disorders. Some of the effects. Typically, it is swallowed, either eaten or brewed as a tea or added to other foods. And people will describe feelings of relaxation, introspection. Some of them describe it like a spiritual experience. You can also get nervousness, paranoid feelings, panic reactions. That can be some of the side effects. The serious side effects can typically come from misidentification and mistaking poisonous mushrooms resembling psilocybin, and that can lead to unintentional and potentially fatal poisoning. Short-term effects people can experience, again, the hallucinations, altered perception of time, inability to tell fantasy from reality, muscle relaxation or weakness, problems with movement, and on the physical exam, you can see enlarged pupils. People can experience nausea, vomiting, drowsiness. Long-term, there has been reports of flashbacks, memory problems. And like Paula said earlier, it's rare that it's not typically that you see a daily use, a withdrawal, or a tolerance. You would see episodic use. Now, where we know FDA approved use, but now it's in research trials for treatment-resistant depression under strict medical supervision. And just a little bit backing up to the epidemiology, we talked about this in actually just a couple of episodes ago. It's been really interesting over the last really kind of 20 years, but this came from the Monitoring the Future study. And interesting that hallucinogen use has been relatively stable the past 2 decades, but then we saw a pretty dramatic increase in just the past really 2 to 3 years. Starting like 2021, we saw maybe 8% of young adults reported past year hallucinogen use. And that was at an all-time high, because compared to, we look at just even from, they were looking at just from 2016, we were looking at 3 and 5% of past year use. And so it's almost doubled just in the past, in the past decade, we've doubled in use. And this is, I think, coming from, we get this like perception of safety, and this, when we get this perception of low risk, then we see this increase in use. I think that's part of it, right, Paula? And then there's all of these supposed reported benefits. And so that's where we put our big, huge disclaimer. We are not in any way recommending that anyone go out and try any of this on their own. We're never recommending that. I do think it is worth talking about some of the research that's out there. Do you want to talk a little bit about a couple of the therapeutic potentials on that, Paula?
Sure. There's a lot of things being studied in terms of the therapeutic potential of psilocybin. There's a very good article published in May of 2021 in the journal Molecules, published by lead authors Henry Lowe and unfortunately, I'm going to not pronounce this other author's name very well, but last name is To Yang. And they look at various studies looking at its potential benefit for alcohol use disorder, stimulant use disorders, specifically cocaine, tobacco dependence, tobacco and nicotine, actually, opioid use disorder, cannabis use disorder, and then anxiety disorders, including PTSD, generalized anxiety disorder, OCD. There's been interest in several studies looking at advanced stage cancer-related anxiety and depression, as well as adjustment disorder with anxiety. There's been look at treatment-resistant depression and major depressive disorder by itself. So more research is needed, but we'll talk briefly about three of these areas of interest. We're going to talk about the studies, the very interesting studies around alcohol use disorder, a little bit about tobacco use and psilocybin, and then the use for treatment-resistant depression, because the mechanism behind this is fascinating. And as healthcare providers, we're getting questions about the use of psilocybin for depression. And much like ketamine for the use of depression, well, actually, the difference being that ketamine, there is now FDA-approved medication for the use of depression that is ketamine, esketamine. We don't have that yet for psilocybin, but yeah, let's talk about that. So should we talk about the alcohol studies first? And there are several, but we're just going to talk about one. Okay.
Yeah.
Alcohol use disorder has been an area of interest with psilocybin, and this is a study that was published in JAMA Psychiatry, August 24th, 2022, so it's very recent. It's titled Percentage of Heavy Drinking Days Following Psilocybin-Assisted Psychotherapy versus Placebo in the Treatment of Adult Patients with Alcohol Use Disorder, a randomized clinical trial. Lead author is Bogenschutz. So in this study, they did find that psilocybin administered in combination with psychotherapy produced robust decreases in the percentage of heavy drinking days compared with those produced by active placebo and psychotherapy. So this was an interesting study. What they did was a double-blinded randomized clinical trial where participants were offered 12 weeks of a manualized psychotherapy. So both groups got the same psychotherapy, and then they were randomized to receive either psilocybin doses, I think it was 25 milligram per 70 kg for the first session, or 25 to 40 milligrams per 70 kilograms for the second session, versus a placebo, not a placebo, but versus diphenhydramine, which is interesting. I guess they use diphenhydramine just because it's also a sleepy kind of relaxant type drug, and they use diphenhydramine 50 milligrams for the first session and 50 to 100 milligrams for the second session. They gave the medication during 2 day-long medication sessions at weeks 4 and weeks 8 of the study. So it's a 12-week study. They get manualized psychotherapy the whole time. They used a combination of CBT and motivational interviewing. At weeks 4, the group either got a blinded dose of psilocybin, 25 milligrams per 70 kilogram, or diphenhydramine, 50 milligrams. 8 weeks later, they got another dose of psilocybin or diphenhydramine. And then they monitored their days of heavy drinking during the 30 days following. So they looked at 95 participants who were a mean age of 46. They had a small smattering of diversity. Most of them were white. There were 14% Black and, 4% Black and 14% Hispanic. And out of the 95 randomized participants, quite a large number of them got at least one dose of the study medication, and they were included in the primary outcome. And what they found was percentage of heavy drinking during the 32-week double-blinded period was 9.7% for the psilocybin group and 23.6% for the diphenhydramine group. The mean difference of 13.9% reduction for the group that got the psilocybin. Mean daily alcohol consumption was also lower in the psilocybin group. So not only did they have fewer drinking days, they also drank less. And interestingly enough, there were no serious adverse events amongst the participants who received the psilocybin. So pretty interesting study, not a huge number of participants, 95, and they randomized 49 of those to psilocybin and 46 to diphenhydramine. But really interesting effect, and the fact that it was a double-blinded randomized trial makes you feel a little bit more confident in the results. There's been several other studies that have similar outcomes to this, so I think we're going to see more to follow. Hopefully we will about this, and there's interesting reasons as to why this may be helpful. But, anything that's going to help our patients with alcohol use disorder is something to continue to pursue and to follow up, and hopefully we'll get more guidance on the use of it. And who knows, in years from now, and hopefully not too long, if it continues to prove to be helpful, we'll be able to offer this to patients. But again, emphasizing that this study included 12 weeks of psychotherapy. This was not just given on its own or self-administered. So this was administered in combination with the psychotherapy. And both groups got psychotherapy.
That is really interesting. And I think it's also really important to note that the dose that was given, this is considered what, quote, we call macro dosing. This isn't micro dosing, because I think that's a really big buzzword that is out there. And I think a lot of people erroneously think that that's effective, but a lot of these studies are actually showing kind of the opposite, that you need to actually give an appropriate dose to patients to get some effect too. Am I
Right,
stating that
25 milligrams per 70 kilograms.
Because typically when you're looking at the microdosing, it's like 1/5 to 1/20th of a dose. So it's like 0.3 grams, quite a bit different dosing there, just to give some a little bit of perspective. So
Yeah,
just,
that's really interesting. Yeah,
yeah.
so then, in terms of tobacco use, there are some interesting articles similarly published on this, one in Scientific American. Johns Hopkins, well, that's just kind of talking about the studies, but Johns Hopkins has done a lot of the research behind tobacco cessation and psilocybin. And starting in 2014, one of the researchers there, Matthew Johnson, did a pilot study to see whether this would be helpful. It was an open label study, so participants knew they were getting the drug. It wasn't like the alcohol use disorder study. These participants also got therapy, so they got what called, psychedelic assisted therapy. The researchers kind of guided participants in terms of, they didn't talk or guide them during the time that the patients had psilocybin ingestion, but before the sessions, they tried to prepare them. And then they did talk therapy and cognitive behavioral therapy for several weeks, aimed at changing the patterns before and after taking the psilocybin. So psilocybin was given in up to 3 sessions, one on the target quit date, 2 weeks later, and then another optional one 8 weeks after people quit smoking. And the subjects returned to the lab for 10 weeks following to have basically laboratory confirmation of whether or not they were using tobacco. And what they found is that at the 6-month mark after this study, where people were given up to 3 doses of psilocybin in combination with the psychotherapy, was that 80% of the smokers in the pilot study, it was a small pilot study, 15 people, had abstained for cigarettes for at least a week, which was a big improvement to other smoking cessation programs where the rates are more like 35%. So again, quite a big difference. When they look at beyond 1 week, Johnson reported that 67% of the participants were still abstinent and quit from smoking 12 months after their quit date. Even 16 months after that, 60% of them had not spoken. So that's pretty good. That's pretty good efficacy. More than 85% of the subjects rated their psilocybin trip as one of the 5 most meaningful and spiritually significant experiences of their lives. So I'd be interested to know if they associated the experience with quitting, because that's the whole connection, right? And in our episode on ayahuasca, it seems like these very deeply introspective experiences that people can have, not always do have, but can have with ayahuasca is what kind of, it's not the only thing, but it's what helps people kind of rapidly move forward to a place where they can continue to abstain, in addition to actual neurochemical changes that happen in the brain. And it's not only neurochemical, it actually seems to be like neuronal, right? Like remapping and that kind of thing. So that's the study that we're talking about for tobacco, Darlene.
Yeah. No, that was a really interesting study. Again, it's a small study. A lot of these are just very small studies right now, but they're definitely interesting, and it'd be interesting to see what else is repeated out there. And there's been multiple trials for depression. When we were researching this, there's been at least 6 of them, 6 major trials on psilocybin for treatment-resistant depression. And one of them, just in this past year, this came out, was published in Nature Medicine in April 2022 by Dawes et al. And it started out with 2 arms. Patients were given 10 and 25 milligrams of psilocybin 7 days apart. And then they gave them a baseline of fMRI. So that's a functional MRI. And that was their baseline. And that was 1 day after their 25 milligram dose. and they used Beck's Depression Inventory as the primary outcome measure. The second arm of the trial was a double-blind placebo, so phase 2 randomized controlled trial comparing psilocybin therapy with escitalopram. So the patients with major depression received either 2 doses of 25 milligram oral psilocybin 3 weeks apart, plus 6 weeks of daily placebo in the psilocybin arm, or 2 1 milligram oral psilocybin 3 weeks apart, plus 6 weeks of daily escitalopram 10 to 20 milligrams in the escitalopram arm. And so they had their functional MRI was recorded at baseline and then 3 weeks after the second psilocybin dose. In both trials, the antidepressant response to psilocybin was rapid and sustained and correlated with decreases in brain network modularity. And we'll talk a little bit more about that, implying that psilocybin's antidepressant action may depend on the global increase in brain network integration. Why this was so this particular study that was so interesting was it goes more into this mechanism of maybe why psilocybin is beneficial in depression. We've used SSRIs for years. We have a fairly good understanding of how they work, and we know that psilocybin and other serotonergic psychedelics have that same effect on those 5-HT2A receptors, but why is it different? So why do patients respond to these where they don't respond to other SSRIs? So there's one theory, and there's this article that I really think explains it really well, and this was written by Laura Kurtzman. It's titled Psilocybin Rewires the Brain for People with Depression. I think this explains it fairly simplistically, talking about you have the landscape of the brain and thinking about those neural networks, and psilocybin therapy flattens out that brain network and allowing it to then reintegrate and rewire. And some people, then they seem, when they rewire, then they come back together better. That's one theory. Then there was another also theory that talks about because we have such plentiful 5-HT2A receptors, they can become overactive in depressions. And because you have that disruption again by the psilocybin, then when they reform in the coming weeks, then you can see that improvement in depression. It's such an interesting mechanism of action. Still a lot of research to come, but I think that also helps us to understand why it helps our patients with addiction as well, because you have so much of that circuitry that has been disrupted by substance use. Don't you think, Paula?
Yeah, absolutely. Fascinating. And there's also antidepressant effects of psilocybin that are thought to be mediated by the action of it in the prefrontal cortex and the limbic brain, especially the amygdala. And, we know the amygdala is associated with fear, and it plays an essential role in perception and emotional processing. And in case of depression, we have this negative affective response to the world. And when people are exposed to psilocybin for whatever reason, it seems to increase emotional responsiveness and decrease the blunted effect and the activity in the amygdala, which is really interesting.
I mean, that's such an interesting thing, like explaining some of the side effects too, when you talk about the amygdala and the fear response that some people get. But I think it's just interesting, some of just how we're doing some of the research. And then I think it's just going to be interesting to see where this goes. But I think it's definitely something to keep following. Not that I don't want our patients going out there and trying this on their own, but I do think it is worth.
Absolutely. And just in review or in conclusion, there's an article that discusses the abuse potential of medical psilocybin according to the 8 factors of the Controlled Substance Act. And the conclusion of this is that psilocybin mushrooms have been used for a long time. Well, that doesn't necessarily make something safe, because alcohol's been used for a long time and it's definitely not safe. But it shows that animal and human studies both show low abuse and no physical dependence potential for psilocybin. They've also done national surveys like the Monitoring the Future survey, and it shows low rates of abuse. Now there's increasing rates of use, but low rates of abuse and treatment seeking and harm. And we also know that psilocybin now has some therapeutic benefits. There's possibility of rescheduling psilocybin. I guess it depends on continuing emerging research, but in the meantime, there hasn't been any significant detrimental short or long-term effects on cognitive functioning or emotional processing. But there are significant harms, including dangerous behavior for people who are using psilocybin in unprepared or unsupervised settings, and also exacerbation of mental illness in those who are predisposed to psychotic disorders or who have a psychotic disorder. So again, people who are more vulnerable and have a vulnerable brain, this is true for any hallucinogen, they are likely to have exacerbation of psychotic symptoms with the use of psilocybin. So that is a warning and a disclaimer.
Absolutely. I think that's really important, that this is absolutely not for everyone. This may be a potential avenue treatment for some, but is something that definitely is very interesting and something that we'll keep an eye on. Okay. Well, sounds great, Paula. Thank you. This was a great discussion. Until next time. Hey, check us out at theaddictionfiles.com or email us at theaddictionfiles@gmail.com. Thank you so much to Ricky Valades for use of his song Awake. Check him out at rickyvalades.com.
Podcasts are for entertainment and education purposes only. Hosts and guests are not responsible for any harm caused by information obtained from this source. As each person is unique, you're advised to seek the advice of your own healthcare professional to treat any medical conditions you may be having. Opinions expressed on this show are those of the Addiction Files and not of our respective employers.